Hi everybody, thanks so much for joining us today. I'm just going to leave you all to look at these images before we get going, just to wait for everybody else to join. So bear with us, we'll just hold on for a couple of minutes. Right, so I think that's enough time, we can get going. Thank you all so much for joining us today for the second installation of the VetCT Winter Webinar series. Today we're joined by one of our lovely radiologists, Lucy Meehan, who works part-time for us at VetCT and part-time in clinic as well. So without further ado, I will hand you all over to Lucy, who will be discussing imaging the stifle more than just x-rays. If you've got any questions, please just keep them to yourselves for now, and then at the end of the session we'll have 15 minutes or so for a chance for you to ask these over to Lucy, and just pop them in the chat box at that point if that's all right. Thanks.
Hello everybody, and welcome to the second instalment of our winter webinar series. I hope everyone's sat comfortably with a cup of tea or coffee, and we'll get on without further ado. So the case we will come back to as part of the discussion, as part of the PowerPoint. So I will get started. So the title I was given was Imaging the Stifle More Than Just X-rays. So we're going to think about what's actually possible when we're imaging the stifle. Certainly as a diagnostic imaging specialist who also masquerades as a lameness clinician occasionally, I find the stifle a fairly challenging region to accurately diagnose the source of lameness. X-ray and ultrasound, I've put frequently normal, but probably what I mean more is that frequently you have mild to moderate changes that maybe don't fit with the degree of lameness a horse is experiencing. You'll often have chronic mild changes in a horse that's acutely lame, for example, or you'll have fairly nondescript changes in a fairly severely lame horse. There have been fairly huge advances in technology and knowledge from an imaging and arthroscopic point of view over the last 15 years with regards to the stifle. And I think it seems that we are still doing fairly similar things with stifle, but there is quite a bit more out there. And one of these major advances has been the ability to undergo advanced imaging of the stifle, so ability to perform CTs, MRIs of this region. And one of my thoughts when I was given this title was, actually, has this changed how we investigate stifle lameness from an imaging point of view? So we're going to try and come back and address some or all of these questions over the next 40-45 minutes. So just very basically, if we start by thinking about the anatomy of the stifle, so I've just got this little 3D reconstruction that we're going to run through here. So this is a CT, and we've got the 3D volume rendering of the stifle. So we're starting at the lateral aspect of the stifle here. So we've got the fibular remnant, lateral femoral condyle, lateral trochlear ridge, and patella. And as we come around to the cranial aspect of the stifle, I haven't included the caudal aspect. We can see we've got a lateral trochlear ridge coming down here, the medial trochlear ridge, which is somewhat broader. Sorry, my mouse is super sensitive sometimes. The medial trochlear ridge, which is somewhat broader, and you can see the more triangular shape of the medial aspect of the patella, the medial intercondylar eminence of the tibia that's sticking up here. And then as we come around to the medial side, we can see that different shape of the medial trochlear ridge of the femur, and we can see a medial femoral condyle. So the osseous structures are fairly straightforward, they're fairly self-explanatory, and we are able to identify those relatively readily radiographically. Where it becomes slightly more interesting is where we think about the soft tissue structures of the stifle. So these two images, one is taken from the Schumacher nerve blocking book, and the other is actually from some CPD I've done elsewhere. And I quite like to compare these two images. So the image on the left to me is the stuff that you can see ultrasonographically. So we've got our patella with the middle and lateral patellar ligaments, and then the medial patellar ligament just sneaking in down here. We've got the lateral collateral ligament of the femorotibial joints, and we can see that we've got medial collateral ligament on the other side. And then we can see the periphery of the lateral meniscus here. And then on the medial aspect, we'll be able to see the periphery of the medial meniscus. So these are the things we can access relatively comfortably ultrasonographically. Now, if we think about the image on the right, this is where it all gets a little bit more complicated. We can see we've got our horseshoe-shaped menisci sort of laterally and medially, and each of these have a cranial and a caudal ligament which attaches them to the tibia. There's a small ligament which attaches the menisci together, which is very infrequently injured, so we don't worry too much about that. We've got the cranial and caudal cruciate ligaments, which are fairly difficult to image with any conventional imaging technology that we have. So radiographs and ultrasound, it's fairly challenging to image these ligaments. Medial and lateral collateral ligaments, which are relatively easily imaged on ultrasound. But I think the thing we have to take away from these images is that actually there's much more going on in the stifle than we can see either radiographically or from ultrasonographic assessment. I just want to bring everyone's attention to this paper. This is a really, really useful adjunct to radiographs and sometimes ultrasound and CT. It's an absolutely beautifully illustrated paper where the stifle was dissected out and contrast was painted onto the origin and the insertion of all of the large ligaments of the stifle. And it's really, really useful if you've got a lump or a bump or a lucency that you're not quite sure whether or not it's associated with anything. This paper will probably give you the answer if it is associated with a ligamentous attachment. So that's something that sits on my desk most of the time. So I just want to share that with you all. So if we go back to our soft tissue anatomy image, which bits are the most commonly injured? We've said that we can't see these bits, but actually, are they important? Are they commonly injured? So if we think about soft tissue injuries of the stifle, going back to some papers that were published in the early 2000s, medial meniscal lesions account for about 68% of the soft tissue injuries in the stifle. Cruciate ligament injuries account for about 9%, and these were mostly identified within the caudal cruciate ligament, so within this ligament here, and the meniscal injuries are usually within the cranial part of the meniscus. This is information gleaned from arthroscopic assessment, and the limitation of this information is that only about a third of meniscal and cruciate ligaments can be visualized surgically. So can we do something that enables us to look at these sites in a little bit more detail? So what imaging modalities are available to us? Radiography and ultrasonography, I haven't really discussed in this, just with the scope of this presentation, but these are our real sort of mainstays of imaging the stifle. They're readily available, often available patient side. Most of us will either have access to a portable digital radiography system or permanently carry one in our cars, similarly with an ultrasound machine. We know that it gives us limited information, but it does give us useful information. And throughout the rest of this talk, I'm going to be talking about advanced imaging modalities and how they help with diagnosis. But bear in mind that a subset of horses that have stifle pain will already have been taken out of the pool of horses I'm talking about, because they will have an injury that or an abnormality that's diagnosed on radiography or ultrasound. So I'm talking about things like OCD, patellar ligament desmopathy, some forms of collateral ligament desmopathy. We'd probably diagnose that before the horse even needs to get to advanced imaging. Where it all gets a little bit more complicated is where we start involving advanced imaging. I've just included an example of each of the systems I'm talking about. So nuclear scintigraphy, excuse the very old picture, but obviously this is a system that has to be used in the hospital. The horse becomes radioactive and the horse has to remain in the hospital for a period of time. MRI, this is again a rather bulky piece of machinery that we're not going to fit in our cars. It has to be used in a controlled environment and the horse has to be under general anaesthesia. Similarly, CT, I'm aware the wrong end of the horse is in the CT here, but just to illustrate that it's a fairly bulky piece of equipment and the horse has to be under anaesthesia for CT to be used. So we have got all of these things available to us, but we have to bear in mind that oftentimes there's significant other work that's involved in using these modalities. So we're going to start by discussing nuclear scintigraphy. Certainly in my practice, it's commonly used for horses that are either low-grade lame or horses that we can't block for reasons of temperament, and commonly also with horses where we suspect an upper limb condition. So there was a really nice paper a few years ago that looked at the diagnostic sensitivity of nuclear scintigraphy for stifle disorders. They looked at about 200 horses with pain originating in the stifle joint. 205 horses that came through a clinic. 23 of those horses had a positive stifle block. And what they found actually was that in these horses that had a positive stifle block subsequent to the nuclear medicine examination, there was actually a fairly poor sensitivity for detection of stifle pathology. So only about 20%, 5% of horses with stifle pain had uptake on scintigraphy. Good specificity, so if the horse had uptake, it was likely to be significant, but oftentimes these horses with stifle pain won't have a positive result on scintigraphy. This is probably because our stifle injuries are often soft tissue, so that's poorly evaluated on bone scans. So actually you can't say a horse has a negative bone scan, it hasn't got stifle pain. The likelihood is that a lot of the time, some of these horses will have stifle pain. Nuclear scintigraphy is significantly more sensitive for traumatic injuries or severe bone lesions. So the image on the right of the screen is actually a horse that is a racehorse that pulled up lame and has a tibial stress fracture. In that sort of horse, so in a lame racehorse, scintigraphy is exactly the right thing to do and is likely to give you a result. However, in the sort of poorly performing sports horse population, which I see a lot of, scintigraphy is very poorly sensitive for detection of stifle pathology. This is the radiograph that goes with the scintigraphy image of our lame racehorse, and then that's our fused scintigraphic and radiographic images, just to show that our region of increased radiopharmaceutical uptake was pretty much in the location of our stress fracture in the corticranial view. So these x-rays might look slightly familiar. These are the ones that were on our pre-case side. So the horse was an 8-year-old Welsh section D gelding who was found toe touch lame in the field 3 weeks previously. His lameness did improve on box rest, but he remained moderately lame at walk. A couple of strides a trot, he was very lame, and then he actually decided to become a Jack Russell Terrier and just carry his leg. So we obviously didn't want to block him at that point. We clinically, he had a moderate femoropatellar joint effusion and probably a medial femorotibial joint effusion as well. And the only other abnormality we found on clinical examination was an old graze to the lateral aspect of the stifle. We perform radiography. I think we can all appreciate that we've got a moderate stifle effusion just here. So we've got quite marked bulging of the soft tissues. There is a small osseous fragment just here. That's quite rounded, and actually on ultrasonography that was just embedded within the medial patellar ligament, and the medial patellar ligament around it was perfectly normal. And other than an effusion, we didn't really see very much on our ultrasound. So after prolonged discussion, we thought it was going to be in the stifle joint. We weren't really, but obviously we didn't really want to block the stifle given the degree of lameness. So he went to nuclear scintigraphy with the caveat to the owner about the lack of sensitivity of nuclear scintigraphy for stifle detection of stifle pathology. I think you can probably appreciate that we have a very marked region of increased radiopharmaceutical uptake at the lateral, so caudolateral aspect of the stifle, which is correlating with the articulation with the fibula. So this horse actually had an acute fibular fracture, which is a really unusual diagnosis. We had obviously seen this lucent line through the fibula on the initial set of radiographs, and we'll come back to the significance of that in a second. This horse actually had 12 weeks of box rest and was sound at the 12-week trot up, so his radiographs weren't repeated. As I said, so when we think about what bone scan added, well, as I said, we could see the lesion radiographically. We knew that we had a radiolucent line in the proximal aspect of the fibula. It didn't look typical for a separate center of ossification. It's obviously got quite a jagged shape, and it has some lucent or lytic areas surrounding it. And there is this irregular new bone formation here on the axial aspect of the fibula. But fibular fractures are uncommon. I spend my life telling vet students that lucent lines in the fibula probably don't matter. So I had to prove to myself that actually this was significant and this would cause a significant degree of lameness. Scintigraphy confirmed that we had a high level of bone activity at this location, and that then fitted quite nicely with the lesion we could see radiographically. Quite why the horse had such a marked stifle effusion was slightly unclear, unless it was sympathetic secondary to just the level of inflammation in the area. And that's just a zoomed in version, so we can quite clearly see this lucent areas surrounding the line centrally and making that fairly indistinct. As I said, it's a shame we don't have any follow-up radiographs. However, the horse was sound at 12 weeks, so it was felt better not to ask the question. So I think, having said all of this, and having said that scintigraphy is poorly sensitive, and that oftentimes in horses with a stifle lameness, we've got a high likelihood of a false negative, the question is, should we use scintigraphy more? Well, I have to say, I do still use a lot of scintigraphy for horses with hind limb lameness, mostly because the population of sports and pleasure horses I deal with usually look at me and think that they might want to kick me. So I think we often do end up using scintigraphy in horses that are resistant to blocking. In these horses, we have to be very aware that we may get a negative result, and we have to be aware that stifle injuries may be overlooked in a horse that's mildly lame that has a nuclear scintigraphic examination. So if our scintigraphy is negative, but we've got a stifle effusion, or we've got thickening over the stifle, or we've got some ultrasonographic evidence, it may well be worth persisting and trying to block these horses, usually under sedation, and usually with the caveat your diagnostic block is going to diffuse further. Sometimes Sometimes we get horses that are already blocked to the stifle, where people or vets ring me and sort of discuss whether or not scintigraphy will be a useful next step. And I have to say, if my horse is already blocked to its stifle, I really do not usually recommend scintigraphy, because I think there are definitely other imaging modalities that would add further information. So I think with scintigraphy, we have to be aware of what question we're asking. We have to be aware if we're asking, is it the stifle or isn't it the stifle, that actually we might get the wrong answer sometimes. But I think it's still a very useful thing to do, certainly in horses that are refractory to blocking, to rule out other pathology, so we can maybe target our blocks a little bit better. That's it for scintigraphy. We're going to talk about computed tomographic examination next. So CT is a really widely available cross-sectional technique. And certainly over the last few years, wide bore or adapted human bariatric scanners have become more prevalent in equine practice. There's a number of commercially available systems, so the Calibra system and the Asto CT system, which are marketed specifically for the equine market and have adapted tables and adapted ways of installing the CT gantry in order to optimize how we can use them to image as much of the horse as possible. The system we see here on the right is one of the Calibra systems. This is a 90 centimeter gantry. They actually do a wider bore that's 100 centimeter gantry, but it's still only a 90 centimeter field of view. This makes it really perfect for trying to get the upper limbs and necks of horses in. Certainly, having seen one of these in action, it does make life fairly seamless to get these horses in once you know what you're doing. So these are becoming increasingly increasing numbers of these over the course of the last few years. There's quite a number of systems now in Europe, and I believe there are some in the States as well. And this means that computer tomographic imaging of the stifle is becoming much more accessible to horses all over the world. Just a note to say that these are all fan beam systems, so traditional helical fan beam CT. There are a couple of cone beam systems on the market, which is a different type of CT technology that I'm not really going to talk about. There are a couple of cone beam CT systems on the market that can image the horse's stifle. The technology here isn't great at looking at soft tissue injuries, which is why I've decided not to talk about them, because obviously we're mainly interested in soft tissue injuries in the stifle. And also the image quality is quite limited in the proximal limbs. So cone beam CT systems are available, but if you want to seriously image a horse's stifle, I think a fan beam system is a much better bet. So this is, as I said, this is a Calibra system. These are examples of sort of bespoke adapted human bariatric systems. This is one from the States, and this is the system at Rainbow Equine Hospital in the UK. There is a similar system at Lip Hook. I just forget to take pictures whenever we're imaging stifles, so I've got that much else to do. So if we think about the technology, CT examination of stifle isn't a new thing. The first publications were looking at this in sort of 2010. There was a nice AAP abstract from Sarah Pachowski and Eric Bergman. There's a couple of isolated case reports as well from that group. And also a really lovely summary of the CT anatomy of the stifle joint was published in 2011 out of the University of Ghent, and that is a beautifully illustrated piece of work. And if anyone is imaging stifles on a regular basis, it's slightly out with the scope of this talk to discuss that, but that is one of the prime resources I would direct you to. So normal anatomy is very well documented. If we think about osseous pathology, that's very visible on our plain CT images. CT is essentially a three-dimensional X-ray, so we get really, really good definition of the osseous tissues. Soft tissue pathology is more challenging to detect. Most of these systems will have a dedicated soft tissue algorithm where the images are reprocessed to help us. But still, within the joint, soft tissues and fluids are next to each other, and they can appear relatively similar attenuations or opacities, so they can be more challenging. In order to help us with this, we do what we call CT arthrography, which is where we inject a high volume of iodinated contrast injected into the joint. So we tend to use about 120 to 160 mils per compartment, and essentially we inject until we get back pressure. Obviously, if we're doing this, we have to remember to decompress these for recovery, because most horses really don't like having a stifle that's distended that much when they're trying to recover. What this does is it delineates the soft tissue structures within the joint. So the contrast material outlines the soft tissue structures and the articular cartilage within the joint, and allows us to assess the size and the shape of the tissues. And sometimes if you've got little clefts in the menisci and little clefts in the ligaments, it can allow us to see those little clefts and see hairs and defects. In the human field, MRI is the gold standard for detecting soft tissue injuries within the human knee or human stifle. However, if in the case of you've got a pacemaker or you've got metal implants that mean you can't have an MRI, they will use CT and CT arthrography, and it's been shown that they have relatively similar sensitivity and specificity for detection of soft tissue injuries within the stifle. So these are just some images that show us how a CT arthrogram would look. So this image here is looking at the cranial cruciate ligament. So you can see we've got this wide band of soft tissue attenuating material, which is flanked on either side by contrast material. This is the caudal cruciate ligament. So we can see we've got this slightly narrower band. The caudal cruciate ligament is longer and more slender than the cranial, which again is flanked on either side by contrast material. Here is a transverse image. So we're looking down on the tibial plateau, and we can see we've got the lateral and the medial meniscus and the medial cranial meniscotibial ligament, which just flows through from the cranial aspect of the meniscus to insert on the tibia. And then we can see here we've got the outline of our menisci. So this is the medial meniscus, this is the lateral meniscus in this horse, and you can see we've got some contrast which has gone between the meniscus and the articular surfaces. So that is the normal. We will just look at some slight abnormalities. So this is a caudal cruciate ligament again, and you can see we've got some contrast material within the insertional portion here. So this has got a mild caudal cruciate ligament desmopathy here insertionally, and you can see this is the meniscus here coming through to the cranial horn, and the cranial meniscotibial ligament has a small amount of contrast there as well. We can assess the articular cartilage with CT arthrography as well. So this is a transverse sagittal image of the medial femoral condyle, and we can see we've got contrast within the joint space here, delineating the cranial and caudal horns of the meniscus. And we've got this narrow band of soft tissue attenuating material here, which is the articular cartilage. It's not always 100% for looking at the articular cartilage. If we haven't got sufficient distension, it's sometimes difficult to separate the condyle from the meniscus. As you can see here in the same horse, this is a lateral meniscus here, and you can see there's a very, very narrow line, but it's not as beautiful and crisp as it is medially. I know this horse had a normal stifle because it had arthroscopy afterwards, or as much as we can confirm. So I don't think that this is a cartilage defect. I think it genuinely is just that we didn't have the lateral femoral tibial joint distended quite sufficiently. The other thing we can look at, which is quite nice, is we can look at osseous cyst-like lesions and assess whether or not these communicate with the joint. So this is a horse that had an osseous cyst-like lesion, which was diagnosed on CT, which wasn't visible radiographically, even when we went back and looked at the radiographs after the event. But we can see that we've got this osseous cyst-like lesion in the lateral aspect of the tibia with quite a marked region of subchondral sclerosis surrounding that. And you can see on the post-contrast image, we've just got a faint blush of contrast right in the center of there. So that indicates that there is a communication with the joint. So CT arthrography is really useful. It helps us look at the soft tissue structures within the joint, and it helps us identify pathology. But previous to having CT arthrography, our gold standard was arthroscopy. So is it as good as arthroscopy? It's a really nice paper that came out of one of the universities in the States, which looking at Western performance horses, so slightly different to the population that I'm used to looking at, but they compared CT, radiographs, ultrasound and arthroscopy for detection of femorotibial joint disease. We're only really going to concentrate on the arthroscopy versus arthrography here. And in summary, what they found was that periarticular osteophytes were more likely to be detected on CT as compared to arthroscopy. Not a great surprise. They do, they're looking inside the joint and not the periphery of the joint with the arthroscope. The meniscal injuries were detected in similar numbers. We can, arthroscopically, it's most feasible to look at the cranial part of the meniscus, but most meniscal injuries do occur in the cranial part of the medial meniscus. So not a great surprise, a similar detection of meniscal injuries. There was a slightly reduced detection of cranial ligament of medial meniscus injuries in the CT versus the arthroscopy. I think 14 were diagnosed arthroscopically and only 12 were diagnosed by CT. So there was a slight difference, so maybe a slight underestimation. This could be partly because there wasn't enough contrast in the joint, or it could be because obviously there's a greater degree of magnification when we're looking at things through an arthroscope, so more subtle injuries may have been detected. There was markedly superior detection of cruciate disease. So most of the cruciate ligament disease was detected on CT arthrography as opposed to arthroscopy. And the thing that they really did have as a take-home message from this is that there was inconsistent detection of cartilage damage in the medial femoral condyle. So if you had a severe cartilage damage in the medial femoral condyle, that was diagnosed about 80% of the time on CT arthrography. However, mild and moderate defects were rarely identified. Interestingly, the population of horses I work with a lot of young sports horses with low-grade stifle pain. A lot of those horses arthroscopically have a condition called chondromalacia, which I think we would struggle to identify on CT, and certainly the few horses that I've put through CT with that type that eventually are diagnosed with that type of condition, the CT has been entirely normal. So depending on what type of cartilage defects they're talking about, low-grade irregularities of articular cartilage probably aren't picked up on CT arthrography. So we're going to just move on to talk about a couple of cases now. So this is a case from my clinical practice. So this is a 15-year-old warm blood mare who presented to us with an acute onset moderate to severe left hind limb lameness. And she had marked resentment of limb flexion and a marked effusion of the stifle. The radiographs she came with had multiple osseous fragments in the caudal aspect of the stifle joint. So our working assumption was a cranial cruciate ligament avulsion. From discussion with the surgeons, we felt that actually going in and scoping that we might not see the most severe part of the lesion because it's very difficult to visualize the caudal part of, or the insertional part of the caudal cruciate ligament. So we felt that CT would be a better way to explore this further. So we're just going to look at a couple of short cine loops of the CT. So this is a frontal image. So we've got the femur here, the tibia here, and we're going to scroll from medial to lateral, lateral to medial. And you can see the purple line will tell us where we are with our sagittal view that's going to come in here. So from lateral through to medial, and if we concentrate on the caudal aspect of the tibia here, we can see that we've got these multiple osseous fragments in this area. If we just go back to midline here, we can see we've got interruption of the normal compact bone of the caudal tibia here. We've got multiple, two large and then multiple small osseous fragments just sat right at the back there. And we've got moderate periosteal new bone caudally. So we are looking at an avulsion of the caudal cruciate ligament here. We've got some mottled opacity within the, or mottled attenuation within the femur. I have to say, I'm still not sure what that is, but it is unusual. If we look at this from, we're going to move from cranial to caudal now. So the yellow line is going to show us where we are. So as we move through in the frontal plane, this is our normal cranial part of the stifle. We flipped, so medial is now to the right. And we're going to go through to the caudal aspect. And here we are with the multiple fragments sat in that fairly wide defect in the caudal aspect of the tibia. We then did a contrast arthrogram. So the patient is to the left here, and this is the normal image that we had earlier to the right, just to illustrate the difference in the caudal cruciate ligament. So we can see the caudal cruciate ligament is a lot wider. So it's probably about twice the width of the normal example. And we have got some contrast either side of it, but less so. I think that's probably soft tissue proliferation within the joint. Our blue arrow highlights our osseous fragment there. So we can see we've got fairly marked abnormality of the caudal cruciate ligament here. So our diagnosis was a partial avulsion of the caudal cruciate ligament with a marked desmopathy of the ligament, the width change, and the soft tissue surrounding that would indicate that there is a desmopathy there. We also had a medial collateral ligament desmopathy, which we can appreciate this medial soft tissue swelling, but we can't appreciate delineation of the medial collateral ligament on the CT. That was actually more easy to appreciate here on the ultrasonographic examination. What did CT add? Well, it confirmed that we had a partial avulsion of the caudal cruciate ligament, which we couldn't confirm ultrasonographically. We know that access to that part of the medial femorotibial joint is very challenging arthroscopically, and the surgeons decided, because we had confirmed that on CT, that we didn't need to put the horse through a arthroscopy as well. There was a concern regarding recovery from general anesthesia in this case, because of the absence of the, or at least partial absence of the caudal cruciate ligament. So this horse, as standard in our clinic, had a rope recovery, but certainly had it not been standard, we would have been at roping this horse because of a concern about instability of the stifle. The second case is an 11-year-old Connemara who had an acute onset lameness 8 months previously. Radiographically, an osseous cyst-like lesion of the medial femoral condyle was diagnosed and a transcondylar screw was placed. The lameness did improve, but does remain present with episodic exacerbation. So CT examination was recommended. So we can see on the frontal plane image here that we've got our large osseous cyst-like lesion and our transcondylar screw. We have got some osseous reaction around the osseous cyst-like lesion, but not tons. And as we come down, as we come from proximal to distal, so the purple line is showing us where we are in our transverse the screw, going through our osseous cyst-like lesion, and we can see quite how much of the cross-sectional area of the condyle that osseous cyst-like lesion occupies. Is quite large, and we can see that there is some sclerosis around that, but not masses. And then we're going to look at a frontal view. So this is the frontal, and this is a sagittal plane, and it's the purple line that we're going to follow here. So we can see as we go through this, we can see that we have our large osseous cyst-like lesion, and we can see that there is a cloaca, which looks like it should be communicating with the joint. The subchondral bone is quite thin and quite irregular as it of the articular surface, so it looks like there's no support to that subchondral bone there. And we can see there is some mild osteophyte production at the medial aspect of the tibial plateau. We then went on to do contrast, or contrast was injected in this horse, which is this series here. So we're just going to scroll backwards and forwards just over the osseous cyst-like lesion here. So we can see contrast between our medial meniscus and the medial femoral condyle. But if we just go back here, there is not really any contrast within the osseous cyst-like lesion, which was a surprise to me. I would have assumed that this would have been filled with contrast material, but obviously there's quite a lot of fibrocartilaginous material within there, which is obstructing or there's some material in there which is obstructing the ingress of the contrast, which is likely fibrocartilaginous. So our diagnosis in this case was a medial femoral condyle osseous cyst-like lesion, and we deduced, given the lack of radiographic change, I haven't got the radiographs here, and the lack of osseous modeling or sclerosis within the medial femoral condyle, that there's been minimal response to transcondylar screw placement. That was no contrast ingress into the osseous cyst-like lesion, would indicate that it's filled with something, but maybe not communicating directly with the joint at the moment. We also had a moderate medial femorotibial joint effusion, which we can see here and here, and it was mild osteoarthropathy, but again, that wasn't as severe as I assumed it would be from looking at the size of the lesion. So what did our CT add? Well, it ascertained whether or not our osseous cyst-like lesion was currently communicating with the joint, and it also ruled out severe secondary soft tissue damage within the joint. This horse had undergone a GA and the lameness hadn't significantly improved, so we're asking the question, actually, did something get made worse at the time of general anaesthesia? It also showed that we had irregular or poorly supported subchondral bone of the medial condyle, which may be a continuing source of pain. And this horse's pattern of lameness was intermittently exacerbation and then becoming sort of more back to baseline. So whether that was part of the issue, we're not sure. But certainly it confirmed that there were still things going on in that medial condyle. But what are the limitations of CT? Well, we know we can look at the soft tissue with our contrast arthrography, but really this tells us only about the margins of the ligament. It doesn't tell us anything about core lesions, and it doesn't tell us anything about the actual structure of the ligament itself. Bone bruising and bone edema can't be detected. Now, that would be really, really handy to know with that case with the osseous cyst-like lesion, whether we had a lot of bone fluid or bone edema surrounding that, and that might tell us whether it's an actively modeling process or not. And we know that subtle cartilage irregularities such as chondromalacia aren't detected. So if we're thinking about a modality that might tell us a little bit more about all of those things, MRI would be the one that would spring to mind. Now, MRI is the gold standard for knee imaging in humans. So given it's the middle of the European ski season, if you or I happen to have an injury on the slopes, often it is a knee injury, and we would probably get whisked straight into an MRI, either whilst we're in the ski resort or when we got back home. Unfortunately, horses are a little bit bigger than humans, and they're a little bit more awkward to position. So MRI examination is very challenging. Most of the available high field systems, the bore of the magnet is too long to get a horse's leg in far enough. But the clever people at ISO80 have invented this system called the G-Scan VET. So it's an open low field magnet. So if you think about the Hallmark magnet, but blown up, anyone that's familiar with that. So it's a U-shaped permanent magnet that can be tilted. So it can either be with the bore running horizontally, which is great for looking at fetlocks and hocks, or we can tilt the bore vertically in order to access stifles. The horse is positioned in sort of semi-dorsal recumbency, slightly off to the side, with the limb extended caudally. There is a handful of these systems over the world. There's 2 in Europe that I'm aware of, 1 in the UK and 1 in Germany, and I believe there's a handful in the States. it's really only possible to examine one limb at once. So the average anesthesia time is about an hour. So if you want to examine both limbs, the second limb has to be done on a separate day. A couple of really nice studies have come out of the groups that are using these magnets. So Martin Vaslau in Germany and Alexia McKnight in the States are using these magnets most routinely. And Sarah Pachowski presented some really lovely information on this at Beaver Congress this year as well. There have been a couple of studies that are widely available. So gross and histopathic correlation of the findings with asymptomatic horses, so validating what we think is normal, and also a clinical case series of 76 cases of horses that have had stifle MRI over the course of the time that the magnet has been installed. So what they've found with these magnets is that soft tissue lesions are commonly identified. So 95% of the horses that underwent stifle MRI have meniscal lesions. Now, all of these horses are horses that were lame and had the lameness localized to the stifle. We're not looking at normal horses here. Concurrent cranial cruciate ligament and meniscal tears occurred in 78% of horses. Now, think back to what we said at the start, that actually cruciate ligament injuries were common, but happened in 9% of horses, but most commonly they were caudal. In this study, they found that actually cranial cruciate abnormalities are fairly frequent as well, and actually more frequent than caudal cruciate ligament tears. So caudal cruciate ligament lesions were seen in 24% of horses. So a lot of horses have soft tissue injuries in the stifle. A lot of horses have meniscal injuries, and concurrent cruciate ligament injuries are very common as well. And actually cranial cruciate ligaments are more common than we thought. Bone fluid lesions or bone edema lesions, those are actually relatively less common. So only about 14% of horses had those. That's in contrast to the picture in human stifle injuries, where a large percentage of people with a skiing injury and a cruciate tear will have a degree of bone edema as well. So it's really interesting that horses don't have those, whether it's a difference in population, that the horses are a chronic population, whereas the humans are an acute injury. It's an interesting thing to hypothesize about. Approximately 43% of these horses had arthroscopy on a separate anesthetic event to the MRI. And this actually confirmed osteocyst-like lesions, 100% of the osteocyst-like lesions that were detected on MRI. So 13% of horses had osteocyst-like lesions. And it also confirmed 100% of the soft tissue lesions that were accessible arthroscopically. So their take-home message is that MRI is useful to estimate the extent of soft tissue injuries and osteocyst-like lesions, and also determine which horses would be most useful for going for surgery. So surgery would be most useful to them. So the images on the right are taken from the paper. So this is a horse with a caudal cruciate ligament injury. We can see there's some increased signal here in the proximal aspect of the ligament. And then this is a horse with multiple focal regions of fluid signal intensity within the cranial horn of the medial meniscus. And then just a couple of other cruciate injuries. So this is again a medial meniscal injury. You can see fluid, a linear area of fluid, and this is what they term a horizontal tear. So a tear that is running from cranial to caudal rather than from proximal to distal, and those were relatively more common. And then we've got an injury of the cranial ligament of the medial meniscus. We're just going to quickly look through a case now, and this is an interesting case to me because I read some of the images and then the horse went to my colleagues at 3 counties for the remainder of the imaging. So this is an 8-week-old foal that had an acute traumatic incident 3 days prior to the initial imaging. And this, so the radiographs that are shown here are the radiographs that I was sent for my opinion. And I think we can also see that we've got a large mineralized body in the caudal aspect of the stifle joint, not too dissimilar to the horse that we saw earlier. We've also got quite a marked soft tissue swelling in the cranial aspect of the joint here, loss of definition of the patellar ligaments, and general effusion, general soft tissue swelling, likely effusion of the stifle. The foal was non-weight bearing on the left hind limb, and a cone beam CT, which I will just show you quickly, confirmed that we had fragments at the insertion of the caudal cruciate ligament. So we can see we've got an osseous fragment here and here, here, and this is the fracture bed here and here. So we can see that we've got those. As I said, cone beam CT isn't ideal for imaging these regions. We haven't got any soft tissue delineation here, and we can see we've got a lot of streaking artifact. So the horse was referred for MRI examination, and my colleagues at the 3 counties who have kindly allowed me to use these images were able to get some really lovely images of the stifle here. So again, this is our caudal cruciate ligament in this area here, and we can see that it widens and becomes much more hyper intense at its insertion as compared to the midsection. And this is just the insertional portion of it here as well. So we can see we've got a caudal cruciate ligament injury, which we knew we had from the images, but the more exciting or the more detail that we have here is showing these are our fat suppressed frontal plane images of the stifle, and what we can see is that we have these blue arrows are denoting areas of bone edema within the medial femoral condyle, and we've also got some bone edema here highlighted by the green images at the origin of the caudal cruciate ligament. And as we are coming through, this is positioned further caudally, we can see that the medial meniscus is slightly medially displaced, and that is because we have a medial meniscal tear, and also we can see our bone edema still, and then there is also what we've called an impact injury on the lateral aspect of the tibial condyle as well. So yes, we've confirmed our caudal cruciate ligament injury in this case, but we've also got bone edema at the origin insertion of that ligament, which not surprising, put it at the insertion because that's where it's all avulsed. But actually at the insertion as well was a bit more of a surprise. We've got a medial meniscal injury, which again makes sense, is quite a large impact to the stifle. There's probably some twisting and turning, so the medial meniscus being injured isn't unusual. And we've also got subchondral bone injury in the femur and the tibial condyles, characterized by this bone fluid signal. And the other thing that we found was a very mild cranial cruciate ligament insertional injury. So what did MRI add compared to the radiograph that we saw at this time of initial injury? Well, it confirmed the severity of our caudal cruciate ligament injury, and it identified an additional meniscal injury and our additional bone edema, neither of which we would have seen on X-ray or ultrasound. And in this case, it confirmed the poor prognosis for athletic function in this foal. So we've talked about CT and we've talked about MRI. How do we make the choice as to which to use, which is better? Up until recently, there wasn't really any information. There has been relatively recently a paper published that compared 3 Tesla magnetic resonance imaging, so higher resolution than the ESO-80 system that's more widely available, and CT arthrography to identify surgically created soft tissue lesions in the stifle. So they looked at 17 normal stifles, cadaver stifles taken from horses with no history of stifle injury. Lesions were created in the menisci, the caudal cruciate ligament, the cranial cruciate ligament, and the cranial ligament of the menisci. Not all lesions were created in all stifles, so they end up with 84 lesions through the 17 stifles. The stifles then underwent MRI and CT arthrography, and they compared the detection rates to the obviously known lesions within the stifle. So what they found was the true positive rate, so the rate of detection of injuries was actually quite between low and moderate, but actually it was similar between the modalities. The discussion that they had around that were that these were surgically created lesions, so you wouldn't have had any of the associated inflammation, edema, or effusion of the joint that you would see with a naturally occurring lesion, Also, these lesions were quite small, and they were designed to be to mimic low-grade naturally occurring lesions. So although the true positive rate was low to moderate, there were some limitations that were able to explain that. The true positive rate was good to excellent, and it was both rates were similar between modalities, and that's important because it tells us that both modalities are highly accurate for diagnosis of normal. So if you don't see anything, it's likely that there isn't anything there, but that small injuries could be overlooked. So there was also, one of the limitations was that there was artifact within the joint from arthroscopy. So you wouldn't normally do an arthroscopy before you did a contrast CT, you'd do it the other way around on ditto and MRI. So they had some extravasation of contrast material, and there was gas in the joint as well, which also didn't help with detection. But the take-home message was that contrast arthrography on CT should be used for investigation of stifle pathology where ultrasonographic examination isn't definitive or where cruciate ligament pathology is suspected. So it is useful. It's useful for ruling out disease, but it's also useful for ruling in disease, and CT and MRI seem to perform similarly. So if we think about all of this, has CT changed how we use conventional imaging? Well, I think there's increased awareness that stifle lameness is multifactorial. Now, when we look at more cross-sectional imaging, we realise that horses with a medial collateral ligament desmopathy may well have a subtle medial meniscal injury that can't be detected ultrasonographically. We know that the cranial ligament medial meniscus injuries can be overlooked ultrasonographically, whereas they are more likely to be detected on CT and possibly even more likely to be detected on MRI. There's also increased awareness of the significance of certain radiographic findings. So this is a really nice paper that came out of Montreal, where compared radiography, ultrasonography, and CT for characterization of stifle OA. And they found this this line here that you can see on this radiograph in this horse with severe stifle OA actually correlated to a ridge of osteophytes at the cranial insertion of the stifle joint. So actually that is quite a reliable sign that you have significant medial femoral tibial joint osteoarthropathy. So I think we are feeding back what we're learning from CT into our interpretation of radiography and ultrasonography. And finally, I think it's made us realize that no single modality has all of the answers. Radiographs and ultrasound, again, tell us different things. We know arthroscopy tells us different things again, and advanced imaging has its place to add information to the jigsaw puzzle. So I think after doing all this and writing this webinar, I kind of came back around to thinking, how would I choose to image a stifle? I would still do radiography and ultrasound as my initial. So my horse blocks to its stifle, it goes into radiography the next day, and then I would ultrasound the stifle and see what I saw. I think then if I'm not seeing anything that would explain the degree of lameness, or I'm not happy that I've got the full picture, I'd then probably just go back and look at the history and think about, is this an acute traumatic injury or a chronic injury? If it's an acute traumatic injury, I may be more likely to go down the route of MRI because I may be more suspicious of there being some bone fluid involved. Or if it's a chronic injury, I may be looking for osteoarthritis type lesions, osteocyst-like lesions, and more chronic degenerative soft tissue injuries, whereby I might go for a CT arthrogram. I think that it often depends, firstly, on the what you've got available. I'm very lucky. I have a wide bore CT available at the clinic. So although I have my colleagues at Three Counties are not far down the road with the MRI, I would possibly be more likely to put horses through the CT for convenience, unless there's a very good reason to go for the MRI. So I think that is key as well. It's always good to use what's available and what you're more familiar with using. And financial concerns, unfortunately, financial concerns are often at play, and frequently we're not able to justify the financial outlay of doing a GA-CT and then following that up on a later date with GA arthroscopy, or again doing a GA MRI and following that up at a later date with a GA arthroscopy to confirm. So oftentimes there's a drive to just go straight to arthroscopy, because that gives us a better chance to diagnose and treat. However, if there's a strong suspicion of a cruciate ligament injury or a meniscal injury in the more caudal part of the stifle, where that might struggle to be visualized, I would argue quite strongly for those horses to undergo CT instead. As a aside to that, as I said, I deal with a lot of younger sports horses with low-grade grumbly stifle lameness, and a lot of these horses will have a degree of chondromalacia. And we know that we don't see that very well on CT. So in that type of horse, if you went for CT, you may have a negative CT, then go for arthroscopy and find the chondromalacia. And certainly we've done that as a clinic. We do that. We do have that process. But again, if we're thinking about finances, it may be that the owner just elects to go for arthroscopy. So I think that's about it from me. If anyone has any questions or any thoughts they'd like to share, that's very welcome. I'm here for the next 10-15 minutes, and I'm quite happy to have a bit more discussion.
Thanks very much, Lucy. We've already got one question up and ready from Sammy Zidane. Is there a difference between low and high field MRI for meniscus injuries of the stifle?
Quite honestly, I don't actually think we know, because I don't think anyone's done the comparison. There's an awful lot of work on normal anatomy in high field systems, and there's an awful lot of work looking at artificially created lesions. I don't think anyone's ever, as far as I'm aware, looked at a comparison between high field and low field. I think the temptation would be to say that high field would be superior. However, the results of the CT arthrography versus high field MRI paper may make us question that slightly more. I think, if I'm totally honest, it's a bit of an academic question anyway, because currently there's no available high field magnet that a live horse can go in, because of the length of the bore. Even the short bore magnets, you can't get the stifle in. So live horses can go in them, but just not live horse stifles. So currently, I think the question of accurate or reliability between low field MRI and CT is a more pertinent question than high field versus low field, just because clinically we can't use high field, and I can't see that changing anytime soon.
Thank you very much. We've got another question here from Lewis Smith, who says, thank you very much for an interesting talk. What was the time period between the placement of the transcondylar screw and the contrast CT that you showed in the grey riding pony?
I would have to look back at the history. I think it was somewhere around 12 months. I'll just see if I wrote that in. I think it was either 8 or 12 months. It was 8 months. So the acute onset of lameness was 8 months previously, and I think the transcondylar screw was probably placed between 4 and 6 weeks after that. So my suspicion is it was between 8 and so between about 6 months prior to the CT occurring.
That's great, thank you. Another one here from an anonymous attendee. From the ultrasound picture you showed at the beginning, could you please remind us which, I believe that would be limitation views you would use to assess meniscal protrusion on ultrasound? Or which position?
Okay, so I just got that one back up. So this horse, sorry, I forgot to say at the time, this horse was a horse that we knew had chronic stifle OA, but had had an acute exacerbation of the lameness. I would normally, so on the radiograph, I think we've got some narrowing of the medial femorotibial joint, which I'm usually very reluctant to call radiographically. I would normally draw a line between the femoral condyle, sorry, the medial edge of the femoral condyle and the medial edge of the tibial condyle. And I wouldn't want my meniscus to protrude more than a couple of millimeters beyond that. So I think this one is pretty obviously not a very happy meniscus. And this is obviously an extreme example. But I find that if they're bulging much more than a couple of millimeters over, I do find myself questioning the integrity of the meniscus. Sometimes, well, I like to flex the limbs to assess the cranial ligament of the medial meniscus and to assess the medial collateral ligament. I find sometimes it's easier to assess the proximal aspect of the medial collateral ligament on flex ultrasonography, just because it's easier to get the probe in the right place. And sometimes I do flex and then look at the meniscus and see if anything's moved in the meniscus as well. I find subtle meniscal tears quite challenging to definitively diagnose ultrasonographically. I will often suspect, and then it's confirmed arthroscopically, but it's very rare with a subtle protrusion that I will definitively hand on heart say, I think it's got a meniscal tear, because I find it quite challenging. But yeah, so I would just draw a line between those two and look at protrusion, and probably 2 or 3 mil I wouldn't worry too much about if it's regular, but anything that goes beyond there I would have a query.
Brilliant, thank you. A question here from Julia Edmonds, who also says thank you. How did the horse in case 2 do? Was there any treatment for the cruciate avulsion?
The horse went for box and small paddock rest. I believe that we don't have, I don't believe we have any follow-up on it beyond there, unfortunately. There was some discussion at the time of going into the caudal aspect of the joint and tidying up what we could. We, being the royal we, obviously that would be the surgeons and not me. But for various financial and age-related reasons, that wasn't gone for. So I think the horse went away for rest and recuperation and unfortunately lost follow-up.
Okay, thank you. Another question, just asking you to briefly or to explain bone edema.
Okay, so yeah, bone edema, it's so bone edema, bone marrow edema, bone fluid signal, bone marrow lesions. They're kind of phrases that radiologists annoyingly use, normally annoyingly use interchangeably, and actually what we're meaning is a pattern of signal alteration that could histopathologically could represent either hemorrhage, fat necrosis, fibrosis, or fluid within the bone. And it is, you're exactly right, it's usually within the fatty tissues, usually within the trabecular bone. You can see the same signal pattern in compact bone, and it's usually secondary to a trauma or a something like an osteocyst-like lesion. So it's a very, I don't want to say lazy shorthand, it's a very widely accepted shorthand for something that could mean actually many different things. The important takeaway point for it is usually, and this is again a very broad generalization, usually resolution of that that signal pattern corresponds to decreased pain. So it is quite a lazy shorthand thing that we use to cover multiple different possibilities that we can't differentiate between on MRI. It's usually high fluid signal intensity in fat suppressed images and low fluid signal intensity on T1 weighted and high signal intensity on T2 weighted images is what we're describing. And it usually corresponds to pain. But further than that, histopathologically, it could be in one of a number of things.
Thank you. Another question from an anonymous attendee, asking how you manage cases in which there is only synovitis, it's negative radiographically, ultrasonographically, and costs limit further advanced diagnostics.
I mean, you've just described the large number of cases that I see. We often have horses that, you know, for whatever reason, we don't go for advanced diagnostics. Most of these horses, I start by putting low dose steroid into the joints. So usually anticortical triamcinolone into usually either just the medial compartment or all 3 compartments, depending on where the synovitis is. Period of rest and gradual ascending walking exercise, which is tailored to the degree of lameness. The lamer the horse, the longer I rest it for. Often try for small paddock rest, or box rest if it's really severe. Gradually increase the walking. I often get a physiotherapist involved to help with core muscle strength and back muscle strength, and helping to make sure that these horses maintain that their strength throughout, and then just gradual ascending walking exercise, very old fashioned. If we end up in a situation where that hasn't improved, we can think about putting other things into the joint, but certainly my first line is steroids, controlled walking exercise, and see how we get on. I usually tend to give them 6 weeks walking, reassess after that, and then gradually ramp up the exercise depending on how things are going.
That's perfect, thank you. I don't know if anyone else has any other questions. Here we've got one from Amro saying thank you, asking if MRI can detect soft tissue injury through chemical changes at early stages before it's obvious on ultrasound. So if MRI was available, would you use it first?
I think it's interesting, and I think we probably can. We definitely can detect soft tissue injuries in different areas than we can on ultrasound. So we can't detect soft tissue injuries in the cruciate ligaments ultrasonographically very easily. So certainly it's helpful for different areas, and certainly it can detect more subtle injuries than ultrasonography in the right hands. Personally, from a cost perspective and from the perspective of just ease, I wouldn't go for MRI first. I would usually go for MRI if ultrasonography was negative or my ultrasonographic findings didn't fit. Certainly, I think that most of the horses that I see with low-grade soft tissue injuries that can be picked up by ultrasound, I think we can usually pick them up relatively early anyway, so I don't see that MRIing them at that stage would be an advantage. Where the advantage is actually assessing the soft tissue structures that we physically can't assess on ultrasound because they're buried too deep within the joint.
Perfect, thank you very much. I think probably in the interest of time, we'll call it a day there. But thank you all so much for attending, and please use the QR codes here just to sign up to the next webinar, which will be on the 18th of April at 7 p.m. British summertime. With our guest speaker, Dr. Jonathan Dixon, and we hope to see you all there. Thanks. Have a good afternoon or day, depending on where you are in the world. Bye-bye.